Welcome to this episode of Morning Report Emergency Medicine. I'm Alec Weir. This is the case of using the ultrasound. See what I did there with the US? See that? All right. Anyways, moving on. This is a 62-year-old lady. She has a history of CKD. Her last creatinine was 6.6 just a month ago. She has diastolic CHF and diabetes. She presents via EMS for shortness of breath times 2 days. She didn't tolerate CPAP via the pre-hospital providers, so she's on a non-rebreather. They tell us she was about 70% on room air when they arrived, and she's complaining of shortness of breath. But even when I'm using the translator, I can tell that the patient is altered. Here are her vitals. She's afebrile at 36.2. Her heart rate's 95. Blood pressure of 154/76. Respiratory rate of 34, setting 72% on room air. So for resuscitation and evaluation, let's try that non-invasive positive pressure ventilation. Let's put her back on some BiPAP, get an EKG and a chest x-ray. We're going to get our lab evaluation, including cardiac markers. We're going to get a urine sample, get an ABG if we can find out if that'll help us decide what's causing this respiratory distress, and we know how much our medicine team is going to want it. And then, of course, we have our ultrasound machine. Here's the EKG you get handed. Actually, not that terrible. Some T-wave flattening in 3, but maybe some peak T-waves in 4 and 5, but, you know, not as bad as it could be for her. So let's get to that ultrasound, right? We want to do an echo. We want to take a look at her heart. She has a history of heart failure. Take a look at that IVC. Is it distended or collapsible? We're going to take a look at the right and left upper quadrants as well as the thorax. So here we have cardiac view. You see she has a small effusion here. It's our subxiphoid view. We're going to switch to our parasternal long. Pretty poor squeeze here on our left ventricle. Right ventricle is seen here. Switching to parasternal short. Again, not great squeeze in the left ventricle. No real bowing of the right ventricle into the left ventricle. And here's our apical. And I want nice work to the resident here. And actually we have a 5-chamber apical. You can see your aortic outflow. And here we have our IVC. So here we're checking our volume status. Are we collapsing? Are we pretty distended with inspiration? And as you can see, we don't have it measured in M mode, but this is a pretty non-collapsible dilated IVC, consistent with some significant volume. Taking a look at the right upper quadrant here, you can see here's our liver and our diaphragm, and this little piece of tissue here, this is a piece of lung just floating in this large right-sided pleural effusion. Take a look at the left, and we've got pretty much the same thing. Here you can see your spleen, your diaphragm, and this little lung bud just flapping inside of a large pleural effusion. Here's a chest x-ray. Exactly what we expected, right? Tons of volume, as well as this large effusion on both sides. Here you can see a second x-ray. It's a little better. Also, there's been a slight change. She was intubated at this time. She just wasn't tolerating the BiPAP. She was becoming more altered, and so the decision was made to intubate. So we've got volume overload, right? We've got cardiac causes, MI, hypertension, non-compliance with medications or with your low-salt diet, or dysrhythmia. You have renal causes, things of worsening kidney disease like hypertension, diabetes, even things like being dehydrated, worsening your kidney function. And then you have cardiorenal causes, where maybe you have an exacerbation of your CHF, which leads to poor output and decreased perfusion of your kidneys and worsening kidney disease, and therefore causing worsening volume. She's at risk for all of these things. So, in the emergency department, she was intubated. Her creatinine was only 4.3 today. She'd previously been 6.6. Her troponin is 0.28. And previously, her troponins had been around 0.13. Not that it's normal, but that is her baseline. Her pro-BNP for us, 18,000. She's never been close to that high. She has a renal consult as well as a MICU consult. Lasix were started in the ED because this was thought to be more cardiac than kidney, renal in origin. But there was talk of possible emergent dialysis. So what are our take-home points? The name of the case, right? Using your ultrasound. We had a good sense of what was going on with this patient by looking at her IVC, an echo, looking at her right and left upper quadrants at those effusions, and seeing the amount of B lines in her thorax. Know your causes of volume overload, cardiac and renal, and then the management of those causes. Well, it's based on the etiology. I won't go into all of those things. It's things that you guys know well already. The point of this case was use that ultrasound to gain as much knowledge as you can right there in the moment. All right, that's it for this week. Keep your eyes out for more interesting cases.